All right. Good morning, everybody. Thanks for coming this morning. We are having a talk about supply chain shortages, healthcare strategies for a stronger future. We are here for, we represent or we are part of Environmental Health Committee of ASA. Dr. Seema Gandhi and Dr. Brian Cheeseborough are our leaders, and we are trying to make a difference here. We have 4 speakers. Dr. Narayan is an anesthesiologist in North Carolina, Carolina's Medical Health Center, and Dr. Molly Har is from Mayo Clinic. She is a division pediatric anesthesiologist, assistant professor in Rochester. Dr. Galaxy Lee is a peds pain anesthesiologist in Jacksonville, Florida, in Humorous Children's Healthcare, Florida. And I am Varun Dixit. I'm a cardiac anesthesiologist at Henrico Doctors Hospital in Richmond, Virginia. We're going to talk about, we don't have any financial disclosures, and we're going to talk about some strategies and see if we can make a difference and have a conversation afterwards. We'll start with Dr. Narayan.
Thank you for coming for our presentation. Thank you for the introduction. I'll be discussing on the supply chain impacts on healthcare and how we can work on it. Oh, is this backwards?
Or spacebar works.
Oh, yes, please.
Oh,
There you go.
A few months before the world stopped, my son was born. Those first few days and nights are very vivid in my memories. I had the responsibility of getting him to sleep, both officially and unofficially at home. You know, it was a lot of work, rocking him, walking him. I cannot forget those days. But every time he fell asleep in my arms, it felt life was endless. Life was fragile. This is all I had wanted to protect for the future. And then the world changed. COVID came like a storm that we had not seen in years. It was the worst public health crisis in century. Streets were empty, hospitals were full, millions of people were affected. No healthcare system, even the most advanced healthcare system, had trouble managing COVID. And they ran into scarcity of supplies. We ran into shortages of all kinds: gloves, masks, gowns, medications, ventilators, laryngoscopic blades and handles and whatnot. The government declared in the March of 2020 that we only had 12 million supplies of N95 and 30 million supplies of surgical masks. It was a mere 1% of what was needed to actually manage the pandemic. Healthcare workers took care of patients like soldiers going into battlefield with just cardboard boxes, like firefighters going into a fire zone without water. We all realized our ability to take care of people, to heal them, is as strong as the supply chain behind it. There were a lot of problems pre-existing COVID. Our national strategic stockpile was empty. It had expired supplies from a prior pandemic. Hospitals had transitioned to a just-in-time model to save dollars. And COVID came like a surge like we had not seen for years. There was scarcity, anxiety of supplies amongst public and healthcare providers. It led to hoarding and misuse. Governments across the globe imposed lockdowns to flatten the curve, to flatten the surge, so healthcare workers had time to take care of the population. It naturally had impacts on manufacturing. Transportation was broken down. China, which was the leading exporter, stopped exporting and imported all the supplies. We all came to a realization: healthcare is not just based on science and compassion. It is based on the logistics behind it. If supply chain breaks, everything breaks downstream. Yet, in the scarcity, we came up with creative solutions. We used disposable masks and reused it many times during COVID. Health systems that had reusable isolation gowns thrived and functioned better than systems that just had disposable gowns. We recreated supplies as isolation gowns and face shield masks. We created overnight through 3D printing face masks, face shields, and nasal swabs and whatnot. We reduced usage by cutting surgeries, reducing unnecessary staff, and promoted telehealth. We innovated through drones and 3D printing, created the shortest vaccine in history. We conserved resources. We reduced wastages in this process. Innovation happens in moments of scarcity, not when supplies are in abundance. Over and beyond healthcare, the entire population of humans came together rapidly and were committed. Engineers, students, our neighbors all became a part of the supply chain. Communities fed healthcare workers that not even met. We all came together with the sole purpose of protecting and promoting human safety. Beautifully, but not perfectly. COVID is not the last supply chain crisis in our lifetimes. Whether it's a landslide, a hurricane, or a fire, or a flooding, it has impacts on buildings. Transportation is impacted. Supplies are reduced. It has consequences on the healthcare industry through delays, cancellations, increase in costs, and whatnot. Whether it's a pandemic, whether it's a virus, or a storm, the impact is the same on healthcare industry. We're all impacted. Hurricane Helene, a 1,000-year storm, ravaged several states in the Southeast just about a year ago. It caused catastrophic flooding in the northwestern parts of North Carolina, a place which was considered as a safe haven. Baxter plant was in the northwestern parts. It is the leading manufacturer of IV fluid solutions in the country. It produces 1.5 million IV bags a day. We all ran into shortages of IV fluids immediately across the country. We came up with creative solutions, and this is what my system did. We developed a real-time dashboard assessing where the supplies are, where it's being used up. We identified high-risk areas and identified within a hospital which are the high-usage area and low-usage area. We looked for alternative sources of supplies. We worked with FDA and AMA to increase the expiry date on IV fluids. At the core of all these strategies, the hospital leaders and healthcare providers came together and discussed and worked on conservation, reducing unnecessary wastage. We came up over 75 recommendations in 13 specialties, and it led to a greater than 50% reduction in IV fluid usage. It's the same situation of crisis. We created and adopted, innovated to shortages, just like COVID-19. Hurricane Helene is not the last storm that you're going to witness in our lifetime. Our government is tracking weather events that have at least $1 billion in economic damages. It is averaging about 9 events a year. And as you can see on this picture, the last few years, it's almost tripled to close to 30 events a year. Climate change is not just an environmental problem. Climate change is a healthcare problem. It is going to profoundly impact the way and how we deliver healthcare. Which is why Congress asked national academies of science, engineering, and medicine to look at what caused this crisis and come up with solutions on how to make it better for the future. They built this resilience framework on 4 foundations, 4 barriers to reduce the impact. The impact is the trigger event that you see on the left side of the picture, and the end impact is on the people that we take care of. The first barrier is awareness, making the data transparent, analyzing the data and sharing it to all stakeholders so we can mitigate any potential disruptions happening in the manufacturing side. The second step is mitigation. It involves updating processes and techniques in manufacturing industries. including resiliency and quality metrics in production, diversification of supplies. The second phase would be preparedness, building inventory stockpilings and capacity buffering of stocks and production within the country. Contingency plannings for planned scenarios and being ready for unplanned scenarios. And the final response is the final stage, is a response both at a global level, which involves international cooperation, and locally involving the stakeholders within the healthcare system to come up with strategies and how we can reduce the shortages. This is what our government has done. We have built the Office of Supply Chain Resilience. We have developed and publicly published a medical device critical shortage list, a device shortage list. Manufacturers need to report to FDA on any potential shortages prior or during an emergency situation. We have 5 devices on the shortage list as of to date. And if you see the graph on the bottom, that's the medication shortage list for over 10 years. The medication shortages existed prior to COVID. It got worse during COVID, and it's still continuing to exist today. The federal government released a white paper about a year and a half ago. It assessed that the supply chain is brittle, it's prone for disruptions, and it's slow to recover because there's a lack of transparency, middleman concentration, unsustainable pricing pressures on the generic drug market. It's recommended to building resiliency programs and bringing in innovation and technology in the supply chain. We have about 48 drug shortages, new drug shortages as of to date. But the deeper question that we need to ask is this alone going to be enough to address the shortages? Yes, the supply chain industry is very fragile. Products and goods are manufactured far away from the point of usage. But what makes it even more fragile is that we have transitioned to a disposable society of practice. Plastic has improved healthcare, but it has also made our supplies disposable because they are cheap. We have transitioned to disposable society and perceived concerns for infection, legal concerns, and cost concerns. Majority of this is not evidence-based. In this context, we have normalized to throw things away. It's the convenience and its cultural norm. It's very easy to throw things, supplies away. All of it disappears the minute you come back in with your next patient. It's pick and clean. We don't realize the impact through unnecessary wastage that we're causing. We exist in a bubble believing that supplies are infinite. In this context, we have normalized disposability, normalized wastefulness in the name of patient care. We have forgotten there was ever a practice of medicine a few decades ago that was based on reusables. Every supply that we throw away, a syringe, an IV kit, an IV bag, a drape, a surgical gown, has consequences that is not apparent to us. So what is it that we can do on our end? Our practice of medicine is based on do no harm. Yet it is clear that the way we practice medicine by throwing away unnecessary supplies is causing harm. We, the healthcare providers, are the one who open up supplies, use a supply, and throw it away. We need to be stewards of conservation and sustainability. Start the sustainability journey within your own health system. Educate yourself and educate 10 other people within your own system. Raise awareness on the wastage that we are causing. We need to rethink our framework. Resources are finite. Pause a few seconds before you open up a supply. Do I really need to open up this second IV bag? Do I need to open up this extra surgical gown? We need to conserve resources at all times, not just during scarcity. And this can be done by transitioning from a linear to circular model of economy, by extending and giving more life to products to rethink, reprocess, reuse, repurpose solutions that the rest of the speakers are going to talk. Sustainability is not just about cutting costs. Sustainability is not about cutting emissions. Sustainability will ensure we are ready, responsible, and resilient for the next crisis that's going to come. Today, I'm a proud parent of 2 young kids. Like any parent, we want them to grow up as responsible adults and be happy wherever they are. but there's a deeper question that ponders in me. Will my kids and the younger generations to come have a place that's sustainable, similar to us, if not better? Imagine this. Imagine your own kids and all of the younger generation standing in front of you and looking in your eyes and asking you, what is it that you've done? What did you not do to make this place sustainable? Imagine this, when each and one of us go back to our own health systems and look at what is the source of wastefulness in our systems. Imagine the innovation that we can spark. By implementing sustainably, it's not just about taking care of patients for today. It's going to be taking care of all the younger generations to come so that they can be sustainable and thrive on this planet just like ours. Thank you.
Hi there, my name is Molly Hare. I'm going to be talking about low-flow anesthesia. Fortunately, we haven't seen the shortages in volatile anesthetics as we have with other things, but it's certainly possible. 5% of the hospital's carbon footprint can come from volatile anesthetics, and low-flow anesthesia is one of the very impactful ways we can improve sustainability. Some of the benefits: it reduces cost and environmental impact. Patient benefits: preserves heat and humidity, decreasing intraoperative hypothermia and airway drying, decreases OR pollution, minimizing exposure to personnel. And it can be done through all phases of anesthesia with some practice. We usually think about it with maintenance, but it can be done with all phases. Quick look at some of our agents, and I'm just comparing different size bottles, and this is an E-cylinder of nitrous oxide. Some of the costs, you can see desflurane quite expensive, about $140 per bottle. Atmospheric lifetime, 14 years for desflurane, 114 years in the atmosphere for nitrous oxide. Global warming potential, and this is how potent of a greenhouse gas it is. Desflurane is 2,500 times more potent of a greenhouse gas than carbon dioxide. And then when you look at using these agents at different flows and what we're going to be talking about. So these are 1 MAC of the agents at 2 liters. You can see desflurane is equivalent to driving 400 miles in a car. But if you drop your flow from 2 liters to 1 liter, that's half as much, so 200 miles. Same thing with nitrous oxide, pretty potent, 122 miles, and then if you drop it, 60. So not in the ballpark of the other 2 agents. And then here are the emissions driven in miles of each of these agents. So a bottle of desflurane over 2,200 miles, an E-cylinder of nitrous over 2,000 miles driving in a car. Talking about sevoflurane and low flow, there have been meta-analysis. This was from 2020 that looked at 41 randomized controlled trials. No significant difference at 24 hours between Sevo and then alternative anesthetics for creatinine or creatinine clearance. It was regardless at varying fresh gas flows, durations, baseline renal function, or the absorbent used. In 2022, Dr. Feldman authored an article in the APSF looking at low flow in Sevo. And basically, the insert will say that, from the FDA about 2 MAC hours, all things like that. But he goes on to say that although sevoflurane can interact with some absorbent formulas to produce compound A, it has never been shown to have renal toxicity in humans. And our newer absorbents have eliminated the strong bases, so a KOH, and then limits the potassium hydroxide to less than 2%. So these absorbents are not even producing compound A in a significant way. This led the ASA to come up with a statement in 2023 saying that the ASA has evaluated current scientific studies, includes there is no reasonable evidence to support a lower limit of fresh gas flow when using Sevo. Therefore, ASA supports the use of low flow gases when sevoflurane is administered. So let's talk about the phases of anesthesia. So induction. When using a lower fresh gas flow, you will have to use a higher vaporizer concentration when ventilating or awaiting muscle relaxations. Flows don't need to be 12 to 15 liters, and I am guilty of doing that for a number of years, but I have changed. So, 5 to 6 liters, assuming you have a good mask, is appropriate. I am a pediatric anesthesiologist, and I too have used really high flows because I'm speeding the induction. But Jeff Feldman has also shown that you can decrease your flows to 150 milliliters per kilogram. And here's a little chart showing, so it's quite low that you can use for inductions. You might have to prime your circuit, but the goal is to have an acceptable time to go off to sleep, which by priming it, you certainly can. So once your fresh gas flow is over the minute and ventilation, there's no rebreathing of exhaled gases, and just increasing your fresh gas flow even more just creates more pollution without any faster induction. And otherwise, pause your fresh gas flow when you're intubating rather than turning off your vaporizer if you can. Most of the newer machines can pause rather than having to dial it down. During maintenance, you can figure out the oxygen consumption, so usually 3 to 5 mils per kilo per minute, and then you can take into account the gas analyzer sample of 200 and leaks of about 100, and then figure out what kind of flows you need during maintenance. There are some low-flow machine assistance, EcoFlow and targeted end tidal control on GE machines, Flow Wizard on Draeger. You need to be careful to avoid hypoxic gas mixtures, however, so monitor and set lower limits for your inspired oxygen, and then also watch your expired vapor concentration, and knowing that you might have to set the vaporizer higher to achieve that MAC. And then during maintenance, there is a phenomenon called coasting. So what we really would like to do would be to turn off your vaporizer early, keep your flows low, and then increase your flows to time emergence. So you don't have to reduce your vaporizer concentration while increasing the flow to get it where you want. So you can coast. This is just looking at Mayo Clinic's, what we've been doing over the past years. I calculated all our bottles and vaporizer into cars. So you can see in 2017, over 1,000 cars of desflurane, and we've decreased significantly over the last few years by avoiding des. We still have it, but going to other agents. So we've done this with education. There are some other opportunities. You can use a low-flow best practice BPA. This is an example that we have. We have Epic, but it will pop up when our flows are over a liter for any agent. So this is somewhat helpful. It's not totally in your face, but it's on our monitors when we are doing this. I was working with some students, and we did an education module, just a 5-minute video explaining low flow and EcoFlow, which is what we use for our GE machines. And then they had a learning module that was on the computer. We looked at fresh gas flow by month, and then total amount of gas used, and then secondary measures were emissions and costs. And what we found is 227 CRNAs mostly did the training, and after their 6 months of the intervention, had decreased flows that they were using, decreased amounts of liters of inhaled agents, and this is the reductions that we saw for costs and bottles. And then it ranged between, 4.7 decrease in sevoflurane to 18% decrease in nitrous oxide. And then you can see the reduction in emissions that we had, over 350,000 kilograms of CO2 equivalents. That was equivalent to taking 83 cars off the road. This is only a 5-minute training module that was pretty darn easy to work with, and then some of our cost savings. Here are some resources that are available. APSS has a low-flow module that's free to anyone, so you can go to APSF and then it goes to ASA, so you can do that. The ASA has a low-flow management tool that was written by the Committee on Environmental Health and has a lot of this information in. And then GasMan by Dr. Jim Phillip is an interactive tool that looks at anesthesia uptake and distribution. So we will keep on moving.
That's great. That's awesome. That's really good. Perfect. Our time.
Morning, good morning. My name is Galaxy. I'm a pediatric pain physician, but believe it or not, they let me hang out in the ORs every once in a while. We're going to discuss the problem with perioperative pharmaceutical waste, mainly IV stuff, after Dr. Hare discussed the inhaled volatile agents, and how we can together minimize the perioperative pharmaceutical waste moving forward. So, as you may know, our work in the perioperative arena is associated with more waste than anywhere else in the hospital. The medical beds, the surgical beds, the ICU. Actually, it comes close to ICU. So there's definitely opportunities for improvement and educational campaigns leading to practice changes that have been shown to be both teachable and effective at all levels, from the CA1 to fresh grad junior attendings to senior anesthesiologists that are 10 years out of, 20 years out of practice, or out of residency. So what you might see here in this picture might be a typical before picture of what's medications that are prepared for general anesthetic. And unfortunately, sometimes all of this ends up being disposed without being used. And that's basically what pharmaceutical perioperative waste is. It's the medication that's left unutilized after the case is done. And as you might guess, this costs money. And they're not maybe, but they're, depending on where you're working, there are environmental consequences to disposing some of these wasted medications. So a prospective observational study of a tertiary care hospital in New Delhi, India, by Chaudhary et al. Sounded the alarms all the way back in 2012, found that the most often wasted perioperative medications included epinephrine, Sux. Actually, epinephrine was 100% based on their study. It was wasted all the time. And, but all these other medications, nearly half, basically 46% of them were all wasted. And then since that study, other countries have emerged with similar rates from their studies. So let's talk about the kinds of waste, routine versus preventable. I haven't taken care of adults in a decade, but I can't recall ever using an entire 200 mics of dexmedetomidine for one case. So that is basically routine or unavoidable waste. It's what's left over in your syringe and your vial after you've administered the intended dose. Now, when it comes to peds at our children's hospital, I remember when I was a resident in the early 2000s, I had some senior attendings who insisted that before every case we had a weight-appropriate dose of atropine loaded in a syringe, loaded with a needle, just in case we encountered pediatric bradycardia. And I'm thankful that I can count on one hand the number of times I've required IM atropine for our cases. But basically, that's preventable, avoidable waste. It's medication that's already been, it's pulled up just in case, and it's not used at all. So over a 12-month period, Dr. Atchison and her team at Mount Sinai, she's now at UAB in Alabama, she basically recorded snapshots of the medications that were prepared preoperatively, kind of like what you saw earlier in this presentation, those 4 or 5 syringes. And this was all for the first case starts, and she compared how much was actually used based on the anesthetic record. And the highest rates of preventable waste occurred with ephedrine, succinylcholine, lidocaine, and our non-depolarizing muscle relaxants. She also found that no association was there with a provider's level of training. So it didn't matter if you were paired up with a CA1 or a CA3, if you had a CRNA with you, or if you're sitting in the case as an attending by yourself. There was a very consistent rate of waste of these medications. She did find that ASA2 cases and higher were associated with increased succinylcholine waste, and longer procedure time was associated with increased waste of rocuronium and vecuronium. So let's talk about the financial costs. As you know, sometimes there are a lot of the decisions that are being made in our institutions are based on financial decisions. And so how do you know how much money is going down the tube? Basically, you compare, you multiply the unit price with how much is being wasted. And to find out how much is being wasted, you just compare what was administered in the anesthetic record with what was actually checked out. In that same Atchison study referenced earlier, their institution's cost of preventable medication waste over 1 year was over $182,000. And remember, unit prices vary through our country, and certainly outside the US. And depending on all sorts of variables, the unit prices goes up and down. Sometimes it really doesn't even make sense. So, but getting involved in your institution's pharmacy and therapeutics committee is really just the first step of making an impact here. The availability of appropriate doses for medications like propofol, which comes in from 100 cc vials to 10 cc vials, is important. And then also the specific concentration of ketamine. Like if you're going to use ketamine, you want to make sure you get the right kind for an IM dose versus an IV infusion. Let's see, what else? Oh, so as far as medications like phenylephrine, you can get those pre-filled. And basically, if that syringe goes straight into the IV, you're saving time, you're saving money compared to a vial of phenylephrine where you need a syringe, a needle, maybe a 250 bag of crystalloid. You could potentially stick yourself. I mean, that costs time, it costs money. So consider medications that are pre-filled syringes. And let's see, prevalence of use. So certain medications like tranexamic acid, sufentanil, we only use those in our places for craniosynostosis repairs, for spine cases. So you don't need to stock those in every OR and wait for them to expire and then just dispose of the sufentanil because no one uses them, for the outpatient cases. So having the forethought of putting certain commonly used meds in the ORs where they're being used makes sense. Oh, and getting back to the phenylephrine. So at our institution, when phenylephrine is aliquoted by a robot under sterile conditions, the shelf life is actually significantly increased. So it does take a little bit of money, but if you work with your P&T committee, you can make it so that you're not dumping expired medications that just aren't being used. So lots of financial costs. As far as the environmental cost goes, Dr. Mankies of Albany Medical College, instead of taking snapshots of photos of what meds were prepared and comparing them with the anesthetic record, this guy, he actually went into the disposal bins of 8 ORs of a small surgical suite for nearly a year. And he found that by volume, he pulled up what was at the bottom of those vials and everything. By volume, propofol accumulated at 45% of total medication waste. And there's an environmental cost. The PBT stands for persistence, bioaccumulation, and toxicity. And it gauges the severity of environmentally damaging characteristics of a certain substance. So and the range is from 0 to 9. So as you may guess, propofol it's an extreme hazard. It doesn't degrade in soil or water. It's toxic to several species of wildlife, fish, aquatic wildlife. And if you read the material safety data sheet, it indicates that it requires incineration of over 1,000 degrees Celsius to destroy. So that costs money, that costs time. But it's important to consider those things as well. None of these medications here should be wasted into the scrub sink. Speaking of disposal, in the past decade, we've all encountered in the media everywhere countless reports of pharmaceutical pollution into our groundwater. So many of you might recognize these black bins down there by your endoscopy suites or MRI that are intended for propofol. At our institution, and many, if not all, in the state of Florida, we have a formal disposal system. This one's called the Cactus, and that's required, mandated for propofol and controlled substances. So that's all of that gets sent to a place that gets incinerated. At our institution, our pain service has consistently spearheaded best practices such as recommending oral over IV analgesics in anyone with pain and a functional gut. What you may not know is that this might have benefits to our planet as well. 2024 multi-center international life cycle analysis was conducted and published by Davies et al. That critically evaluated the steps in the use of acetaminophen, Tylenol, from chemical synthesis, that's production, to creating it in tablet form versus liquid form versus IV form formulation, to the packaging, making the blister pack, making the bottle that the IV goes into, to sterilization, how much it costs to do that, to distribution, how much it costs to put that on a giant ship to send it to us, and then the equipment that's needed, like a little paper cup for the acetaminophen tablet versus IV bag if you're going to run an infusion versus a little plastic syringe if you're going to give it orally, and then the disposal costs. And they did this for 26 hospitals. And their team found that the carbon footprint, as measured in CO2 equivalents of using IV acetaminophen with a glass vial, was actually 16 times that of a tablet formulation, and using it in a plastic vial was surprisingly only 8 times that of a tablet. But that was primarily due to the packaging, manufacturing, and supplies. They then retrospectively audited the perioperative practices and costs in these 26 hospitals in the US, the United Kingdom, and Australia to calculate the environmental and financial costs that might have been saved if tablets were actually administered instead of IV acetaminophen. They found that 57 kilotons of CO2 equivalents, or 88.6% of total emissions in a year, would have been saved. And with the same proportions that Dr. Hare shared with us, that equates to 21 million miles driven, or over 3,000 cars driven over the course of a year. The cost analysis was actually that over 98% would have been recovered if oral acetaminophen was given instead of IV. And that's not surprising, given that a year or two ago, a tablet in the US cost 5 cents compared to $26.50 for a vial of acetaminophen. Oh, and that's what we're talking about, the cost analysis. So what are we going to do to try and get this more limited? First thing you want to do is you go see the patient. Go see the patient before preparing your meds. Tell the resident to just hang out or come see the kid with you and prepare those meds after you make sure that the kid's not been chomping on a candy bar and, NPO violation. Or sometimes they've got URIs and you've got to cancel the case. But that's a big deal for some of these spine cases. Sometimes that happens. You have same-day cancellations, and I get it. It's very disruptive. But let's confirm some of those things before we prepare the meds. Consider using pre-filled syringes, many of which have a longer shelf life, like we talked about. There are IV infusion calculators that are handy-dandy. So if you want to know whether you need 2 50 mic vials of Remy or sufentanil, you can use this calculator based on the weight and how long you're going to be using it, or 1 250 mic vial. So that's very basic, but it works. And same goes for propofol. Dr. Mankey's team in Albany, actually, when he did his study, they had just eliminated the 50 cc and 100 cc vials of propofol, leaving only 20 mil cc vials. And they found that their waste decreased from 29 mils of propofol every day per bin to less than 2.9 milliliters of propofol per day per bin. And in case you didn't know, back in 2014, the 10 cc vials of propofol was when those were first emerged, and we're seeing, a reduction in waste in our children's hospital. Specifically regarding propofol, you can use this QR code. It's a handy-dandy tool that was developed by the spouse of one of our colleagues. And if you click on that QR code, it pulls up this website. And basically, you just plug in the weight of your child, how long the MRI is going to be. As you may know, brain MRI, they're all about 20-something, depending on contrast or non-contrast. So this is easily reproducible. It's a very basic thing. And then if you know you're going to go 200 mics per kilo per minute, you put those 3 variables in, and at the bottom it tells you just 120 cc vial is all you'll need. It is kind of basic, but it does the job. And there are newer ones that actually just came out in the past couple of years that are more sophisticated, savvy. This one on the right is a TCI-based application for smartphones that actually allows 9 analgesics, 7 hypnotics, 3 neuromuscular blockers, and even like TXA boluses. So be on the lookout for new technology when it comes to that. Thanks.
Thank you very much. So I'm going to talk about some basic strategies of waste reduction and reusing supplies. We have to take care of our patients, so it's inevitable we use some of the supplies, and we have to take medications out and take care of things. But we heard before what things can be done to mitigate the pharmacy waste or low flow anesthesia. But once the clinical process is over, I'm going to talk about what to do with on the other side of the waste. Waste management is a problem in clinical ORs. Hospitals produce around 5 million tons of waste every year, and that can be broadly classified as general waste or non-hazardous or non-clinical waste, and red bag waste or clinical waste or regulated medical waste. I'm not going to go into sharps or the pharmacy waste because that's already been covered. I'm just talking about those bags of piles and piles of bag we produce after every single case. Now, clinical waste, the way these wastes are taken care of makes a difference because clinical waste can be disposed in a general landfill without much processing. But the regulated medical waste or the red bag waste has to be used either autoclaved or incinerated. So there are financial costs to it, massive cost to it. So clinical waste accounts for roughly 2/3 of disposing, and the environmental cost is 1 kilogram of regulated medical waste release at least 3 kilograms of carbon dioxide. The problem is not just that. Well, we can say clinical practices need waste to be produced. It's inevitable. The problem is not just that. The problem is 70% of the regulated medical waste is actually not necessarily a regulated medical waste, can go into a general waste or a white bag waste. There are multiple reasons why that is a problem. Ranging from lack of awareness, people don't know what is classified as regulated medical waste. Some people think that if it touched the patient in the OR, it's considered a regulated medical waste or clinical waste versus it's just not convenient to do it. For example, this is a picture in OR in my hospital. You can see the regulated medical waste or red bag waste having things like bags, gowns, gloves, anything which people don't know what to do with and they just dump in it. So I started asking around the staff, why are you putting this stuff in here? It does not need to be in the red bag. And I got different answers, which was interesting, ranging from people saying, well, surprisingly, a lot of people actually knew that it should not go in the red bag waste. So then I asked them why it is not in the white bag. The problem was the quality of white bag because it rips very easy and they have to use double bag or things like that. So we just put in the red bag because the red bag waste is more robust. That makes no sense, but that's a practical problem. And if we are not doing it, we don't understand it. But people who are actually taking those bags out and getting it ready for the next case, that can be a problem for them. Another problem I realized was where those bags were. For example, the picture on the left, this is a picture of our cath lab. And you see that white bag on the corner where the procedure table is. And that used to be a red bag. And every time the proceduralist will come in, put the gowns on or change the gown or the room was being prepared, all of that was going in the red bag. Why? Because it's a big bag right in the middle and it's easier to put stuff in it rather than walking 2 steps and putting in the white bag, which is a little bit further away. The other picture on the right is In the cardiac OR, where I work usually, before the patient goes on heart-lung machine, all the material which was collected before the incision is even made, for example, lining up the patient or prepping the patient or putting a Foley on, all of that stuff was being put in the red bag, which is close to the perfusionist, which is right in the middle of the room. There is a white bag in the OR as well, but it's further down towards the feet of the patient, and it's just convenient to have the red bag right there and dump things in there. And once you get into a flow of doing things and you're busy, you don't pay attention to these things. So keep constantly reminding them is a way to do it. But if you just change the practice and make it easier, people will do the right thing because it's convenient. So what I did was I changed in the cath lab the red bag to a white bag. We still have a red bag, don't get me wrong. It's not like we are eliminating it, but just make it a little bit harder people to think when they are putting stuff which is saturated in blood and appropriately needs to go in the clinical waste to make an effort to do it. But the general waste is right there. And I put a white bag inside a red bag in my cardiac OR. So what happens is, and that this bag stays close where the perfusionist is. So when the patient gets lined up, and as I said, all these processes before we go on pump or before we make an incision, all this, the stuff which I showed earlier in this here, this gets collected in a white bag. And once we go on pump or once we make an incision, when I think the real red or clinical waste is going to be produced, I take this white bag off and dispose it off accordingly. That has reduced our red bag waste, but it also saved a lot of money because we are not a very big hospital. We are a 300, 400 bedded hospital, and we are spending $6,000 a month to get rid of regulated medical waste. So if we can reduce that, that can be significant cost savings. Now, once the general waste or the white bag waste is produced, that does not always have to go to landfill either. I started a recycling program some time ago in my hospital. And what we do is everything which is recyclable, which includes hard plastic, cardboard, and paper, is collected in a separate bag. Most of the time before, while the case is being prepared or before the patient comes to the OR. So it's pretty clean, not sterile, but very clean. And we have these receptacle on the left side. These every OR in the operating room has this. This is clearly marked, but also has a unique color bag. In our case, it's green, but it could be anything. So it's hard to be confused between putting general or clinical or regulated medical waste in this kind of a stuff. So in this kind of a bag. So it's green and it's very clearly marked. And once it becomes a routine or habit, people know what goes where. These green bags have the same process in environmental services through the OR. And in the loading dock, we have a container which is, again, clearly marked on the right side, where we collect all the recycled material, which is picked up by a recycling company and taken care of. When I started this process, I was not sure how much are we recycling. I was not sure how much is recyclable or not, because a lot of times we think things can be recycled, which cannot always be recycled. But we created a huge impact. We were able to divert 180,000 pounds of waste from our ORs, which is equivalent to 280 metric tons of carbon dioxide, or roughly taking 55 cars out of the road. We were recognized for our work. We got the Virginia Governor's Environmental Excellence Award and National Pollution Prevention Roundtable. So another thing I got involved was reprocessing of equipment. As Dr. Narayan mentioned in his talk, our supply chain is very fragile. And as he mentioned correctly, with these natural disasters and pandemics, we are seeing these problems happening more and more, and there is no end to it. Reprocessed equipment strengthens our supply chain. It brings the manufacturing from some other country or some other place closer to home. It can save also virgin material which are used to make those products. Contrary to belief, the reprocessed equipment goes through a very, very stringent process to get them ready for the use. It's FDA approved. They are individually taken apart, cleaned, sterilized, replaced, and inspected, packaged, and sent back for reuse. So there shouldn't be any concern of a lower quality or any sort of infection, because these are done by very highly regulated industries. The provider, we have 3 different providers. I'm giving one example, the Stryker, which we use for our practice. We have imaging catheters and diagnostic catheters and ultrasound, intravenous ultrasound catheters, which they all have reprocessed. And the cardiologists and the surgeons don't see any difference in quality. This simple change can reduce our chemicals usage, water usage, and overall carbon footprint significantly. The other things which can be reprocessed are disposable scissors tips, harmonics, LigaSure, MyoSure. These are simple equipments for open abdominal cases. We have these blue boxes on the top left corner which have clearly marked what goes in there. These equipments are collected there. They are clearly marked by Stryker and then taken to their facility where they are reprocessed. We also have receptacles in the PACU and recovery where we can collect our EKG cables, pulse oximeter, compression stockings, and BP cuffs. Ideally, we should just be able to clean a BP cuff and use for every single patient, but we do have a single use, but at least we are reprocessing. So it's not the ideal world, but as an anesthesiologist, these are corporate decisions make much higher than we, and there are cost things involved in it. So there are a lot of other things which are beyond my control, but what we can do still make a difference. Stryker gave us a silver award last year, and this slide is important to show that reprocessing is not just good for the environment, because if you go in C-suite or talk to the leaders, they are not very interested in that. But if you tell them you're going to save hundreds and thousands of dollars, in our case, is $600,000 for a very small hospital, that is very, very significant. Another innovative change we have implemented in our hospital to reduce the regular waste or the white bag waste is start composting in the cafeteria. So anything which is not consumed or wasted during the processing of food in a cafeteria is collected by a third party. Now, why it is important is composting actually fixes carbon and reduces methane production in a landfill because it's aerobically decomposed rather than anaerobically decomposed. So that also reduces our white bag. So ultimately, we can recontract our clinical waste and non-clinical waste and see if we can get a lower price for that. That should pay off some part of at least of recycling and composting. Because not everything saves money. Composting and recycling costs more, but by reducing our overall waste and by doing other strategies like reprocessing equipment, it can pay itself off. We also implemented some other invisible wastes, as Dr. Hire already said, low flow initiatives, we implemented that, and we cut down our sevoflurane use by 25%, saved like $35,000 for the hospital. Again, we are a relatively smaller hospital, so it's a pretty significant cost cutting for us. Building on that, we were able to discontinue our pipe nitrous oxide 2 months ago. That should help the environment because we are buying H cylinders of 42 of them everywhere. And I looked up the usage. We are only 1% providers actually use nitrous. So all of that nitrous was just going straight on the environment. But it also should save $8,000 to $10,000 for us going forward. So in summary, there are many ways which are practical and actually economical if you put them all together to reduce the waste. It's inevitable to produce some waste, but you can be more judicious about it. As other speakers said, we don't have to use more supplies, reduce, reuse, and recycle. Some of the waste is inevitable, but even then you can recycle or reprocess a lot of them, which can be reused. We reduced our regulated medical waste. We recycle some of the stuff. We reprocess our equipment. We started composting. We also implemented low flow and pipe nitrous. And we saved a lot of electricity by switching all the lights to LED in our hospital and taking Desflurane out of the pharmacy. So those are some of the things we implemented, and hopefully build up more changes on these innovations. Thank you for the attention. We're ready for any questions. Thank you.
Mike Scocci from Roanoke, Virginia. I guess my question is, I've encountered some things that I thought were simple fixes, but for example, one of the issues that I see is like we have Draeger machines, and when I first go to turn the anesthetic that flows down, there's a microprocessor issue where it like locks at 3 liters and it says it can't reduce it further, and it pauses but a lot of the cases I do are very they're very involved cases, cardiac, major vascular, and I've already moved on to do other things. And sometimes I notice 20, 30 minutes goes by as I'm lining up the patient, checking blood. And in some cases, people just, forget altogether. I do appreciate the fresh gas flow warnings, but have we tried to do anything with industry to try to target some of these practices? It seems like it would be a simple programming thing. If I want to go down to 1 liter, okay, reduce your flow, and then when it's practical to do so, then reduce it further as opposed to a hard stop. Have you guys, had any kind of interactions with industry for that?
I mean, I can tell my experience, and I'll let other speakers talk about it. What we did, so in our machines, we had a 2 liter, 2% default. So if you touch that, it'll take you for 2 liters, 2% default. And I said, can we change that? It was a program issue. We needed the code from the company. We got a GE guy come in, but we were able to change the programming. It takes a little bit of work, but you can change it to 1 liter and 70% oxygen or whatever you are comfortable with. And that definitely helped. The compliance is also, we were able to change the practice because it became much easier. People would just go to 1 liter instead of 2 liters. So I think it'll change. If you contact Draeger, they should be able to change the programming. It takes a little bit of work because those codes are not easy to come by, but it definitely can be done. I don't know what other experiences are.
We have GE machines that are placed. It's a similar situation where the soft keys that are programmed into the ventilators are all higher flow rates. So we work with GE and we reduce the default keys and the soft keys. So when you hit the default keys, it goes to a liter as the default setting. So I think that is one that makes providers to accept low flows easier. It is one less step for them to cut the flows from 2 to 1 liters manually. It helps change behaviors. And makes it easier for providers on a day-to-day practice. I don't know about Draeger's, but I think that you should be able to do it if you reach out to Draeger.
Yeah.
Jim Suchik, University of Michigan. Used to be on the Committee for Technology on the APSF, as well as briefly on the sustainability, environmental stuff. So I'm a skeptic on the environmental things until you can get China to stop building coal-fired power plants. All of our contributions medically are a drop in the bucket compared to that. The nitrous oxide at Michigan, we've managed to take it out of the pipeline, which is dramatically, most of the nitrous that we were buying was just escaping through leaks in the pipeline. So we still have nitrous available to use. I'm working on an educational paradigm of how to use it most efficiently if you want to use it during a case. I've done closed circuit and liquid injection anesthesia, and the GE, we have their low end tidal control, and I can beat it if I work hard, but not by a lot. So these things of automation, as you discussed on the computer, do have great impact and decreases the cognitive load and makes it easier for someone who's not truly trained in low-flow anesthesia. The trade-off is you will increase your use of soda lime. And that's something that always needs to get put into the equation. It can be treated as a toxic waste, even though theoretically it just turns into chalk. calcium carbonate, but there may be residual leftover strong bases in there, hopefully small amounts. The trade-offs are always there. I never envisioned in my life that I would see disposable fiber optic scopes. However, when you weigh the cost, both to the individual patients and to the healthcare system, of a single failure to appropriately sterilize, which has happened in some endoscopy suites. They had to send out 50,000 notices to people that you may have been exposed to somebody who had some disease. And we're approaching a zero risk tolerance for that. We don't want to ever have that happen. And so I sort of said, you know, we can't track everything else. And there's a lot of what you say about the no data. When you go to a restaurant, the silverware you use hasn't been high-level disinfection, yet our ID people are insisting we use high-level disinfection for our laryngoscopes. And it's like, where's the data sensibility in that? Pre-made syringes, great idea, both for safety and for decreasing the waste. So you can have your atropine syringe up on top of the cart, your epi syringe up on top of the cart, and not opened. Plus, you can scan it and have a double check on your doses there. So that's sort of one of the win-wins, because some people are very afraid of disasters, and when you look at the cost of that waste, you have to weigh it at the cost of a neophyte struggling to draw up the atropine and the kid's turning blue without a heartbeat. That's not a position you want to be in.
I'll say one thing about, you mentioned China. I'm not advocating China, obviously. Since they produce almost everything, they are the manufacturing hub of the world, it's inevitable they will be using more.
We've outsourced a lot of our pollution
So-
to other places,
So
and
they are inevitable, and they are also building, again, not an advocate of China by any sense, but they are also switching to green solar panels and wind more than anybody else. Anyways, that's a conversation I'm not going to get into. But yes, your concerns are definitely valid, and that's the reason we are moving towards where we are as single use. The point is not to just completely abandon single use. The point is, can we still work more
But if we can
sustainably?
move more things domestically, we can then have more sustainability and more control and better
That's the-
accounting
that's
of what we're actually generating.
Yeah, that's the whole message. It's not about we should abandon single use and go back to where your concerns are obviously reasonable.
Thank you. The only thing I'll say is some of those single-use, like the low-level disinfection, blood pressure cuffs, pulse oximeters, those kind of things are, to me, a no-brainer that we shouldn't be using single-use. It gets more complicated with channels and things like that, but there are handles of laryngoscopes, you know? I mean, there's a lot of stuff that we've already
Yeah.
gone with.
Again, we get that conflict between the infection control and everybody else, and it's like, I don't have.
So I think at the end of what we say as sustainability people is we also promote and support safety of our patients. We are not asking people to implement sustainably at the cost of patient safety. But there are clearly, as you've seen in your practice, the disposability is causing unnecessary harm and lots of wastage. And if you look at the entire U.S. medical industry, we produce about 10% of our national carbon emissions. So it comes, and majority of the carbon emissions that comes from a hospital is from the operating room. So we are the top contributors. So looking at how rethinking processes, how can we reduce this wastage? What is it that we do? If you look at the supplies that we throw up from the back table, they throw so many unused surgical gowns, surgical lights. There's lots of wastage that's happening there. So I think that's where we need to look and reducing our wastage. And I think Dr. Jody Sherman looked at, should we go up on the gas flows higher, or should we reduce to keep the gas flows low and change this CO2 absorbent canister. I think where she ends up saying as an expert is that in the context of where we are, it is better to keep the flows down and change the CO2 canister. So that's where her recommendation is.
Absolutely, I agree.
And I think with the deadenoscopes that went into a problem, there were issues, or they were not properly sterilized, or there were some issues. That was the only isolated situation that happened. But we have since used so many other ways to sterilize and clean equipment. So there needs to be a national policy that needs to be developed on appropriately categorizing devices and equipments, which is low grade, medium grade, and high grade, and develop national policies for sterilization.
Thank you, everyone, for coming.